Hi, I'm Dr. J. Varma, and welcome to Thermometer. On this channel, I check the temperature of health in the US and around the world, and I give you expert insights on infectious diseases and public health. This is our weekly episode of Inside Outbreaks. And on these episodes, I review the latest outbreaks of infectious diseases, outbreaks that you need to know about. And I do this with my friend and colleague, Dr. Jon Epstein, a veterinarian virologist and disease ecologist who, like me, has spent his career tracking dangerous infectious diseases across all corners of the earth. Thanks, Jon, for joining me today.
My pleasure, Jay. Good to see you.
Yeah, it's great to see you. Now, there's been a lot that's been going on in public health. I mean, almost
always,
really well, almost too much to keep track of, obviously, because here in the United States, there's this effort to kind of dismantle the infrastructure. And we know that globally, a lot of wealthy donor countries are sort of pulling back. And then we also know that there's been a lot of capacity built in other countries. So no matter what would happen, we were going to start to see more outbreaks detected around the world, whether that's due to more risk, more detection, or a combination of both is always the underlying question.
And they're not mutually exclusive. I mean, yes, the more countries are able to detect and respond to outbreaks, but we know, and the science tells us, they're happening more frequently too.
Absolutely. And so that's why we wanted to shift things around, at least let's see how this works for the next couple of episodes. And instead of, as we have been doing, which is just an in-depth discussion of maybe 2 or 3 big outbreaks, we wanted to start a new segment, our infectious disease rounds, where we're just going to do kind of a little lightning round of some of the most important outbreaks that we're tracking, mostly here in the United States, but some of them around the world as well, too, and just give you a few quick updates on what's going on with them, as well as our insight into them. How does that sound, Jon?
Yeah, that's great. It gives us a chance to touch back on maybe things we covered more in depth previously and update on current situations. I love it. Let's get into it.
Good. All right. Well, number 1 is going to be Ebola. And this is a topic that we covered quite a lot in an episode of ours two times ago. And so there's an Ebola outbreak in the Kasai province of the DRC, the Democratic Republic of the Congo. And the number of cases has now increased to 57. 47 of those are laboratory confirmed. And the current case fatality rate is estimated to be 53%. And what that means in very simple terms is about 1 in 2 people who've been diagnosed are actually dying from this disease. Jon, you're a veteran of Ebola outbreaks. What's your reaction to what's going on right now in this update?
Look, I think from what I've been reading and what I know about the response to this, it's very well organized. It's largely happening, via the government of DRC with WHO assistance. And what I think is they've done so much contact tracing, they're probably now reliably finding cases when they report, at least clinical cases. So these numbers don't surprise me. They're probably getting a lot of detections. I'm sure there are many that they're missing, that might be on the more rural, remote areas. But what I really think is important is that they're deploying vaccines, they have monoclonal antibodies, they have treatments available. I think they really have a handle on this. And what we're looking for is for those cases, of course, for new cases to decrease to 0, right, Jay? So that we can, after 2 incubation periods, then say that there's no more outbreak going on. So an incubation period being 21 days. I think we need 2 of those periods to pass with no new cases detected to say that the outbreak's over. We're not there, but that's the goal.
Yeah, no, absolutely. I mean, I think the good news here is that I don't think the outbreak, at least based on the data that's been presented, appears to be growing at the sort of the exponential rate or in the sort of geographic distribution, like spreading to lots of places. That normally is the most distressing sign, of an outbreak out of control. But it is worrisome to see these incredibly high case fatality rates. I mean, one of the lessons of the massive West Africa Ebola outbreak from 2014 to 2016 was the first time that, Ebola cases were managed in the United States and in other parts of Europe. And what we found is that when you have high quality medical care that's delivered, the case fatality rate is not 1 in 2, right? It can be less than 10% and sometimes less than 5%. And so I think that's one of the things, we need to keep watching as more outbreak control measures become localized. That is, countries take ownership of these massive responses like they have in the DRC, to also see whether there can be improvements in the quality of medical care that's delivered after people are diagnosed, so that, the rates of death are not quite so high.
That's true. I remember learning during the West Africa outbreak, speaking to a colleague who was on the ground treating patients, how important rehydration was, that IV rehydration for a case could help get them through some of the leaky vasculature that causes some of the hemorrhaging that occurs, it gives the body a chance to fight off the virus and for the immune response to settle down. So sometimes, simple and available treatments can be very effective.
Yeah, and it's no doubt that fluids as well as nutrition, right? And one of the
Mhm.
other big challenges, of course, is these tend to occur in areas where people are relatively undernourished, and they probably have a lot of underlying infections, things like
Right.
tuberculosis, HIV, parasitic infections, which can also make it more complicated. So it's not likely that you would be able to get the case fatality rate down to the level that you get in a lot of the cases that occurred in the U.S. and Europe, which were Westerners who had traveled there, to provide medical or supportive services. But at the same time, we would hope that it could be reduced with better medical care over time.
That's right.
Let's.
And it's, yeah,
Oh, go ahead,
sorry,
John. One more
let's
point.
move on. No, we're lightning
Okay.
round, so
All right, lightning
we'll
round.
keep it
Okay, yeah,
moving.
just like on rounds in a right, just like rounds in a hospital. I'm going to be attending and push you along. All right, number 2 here is measles, and we're coming back to the
Measles.
United States here.
Mhm.
Now we know that the big outbreak that started a lot of the measles concern and conversation this year was in Texas earlier this year. But I think what's been less understood is that outbreak eventually seeded outbreaks all throughout other parts of the United States, particularly in the Southwest. And you're seeing a very large and growing epidemic in Arizona and Utah. And so far, you have over 1,500 measles cases in the United States this past year. Now, the United States is a country that we had previously announced and been very proud of, eliminated measles. That
Mhm.
means there was no more transmission occurring only within US borders. Everything was caused by importations. But we're really in danger of basically losing that status as cases continue to spread in other places around the United States.
The only thing that's going to keep these numbers down and even get us back to eradication is consistently high rates of vaccination. And as long as we have these pockets and communities that dip below that protective threshold of 90s, 95% that we need a vaccination rate, or up there in the 90s, we're going to be susceptible to these outbreaks and ongoing transmission. Measles
Yeah,
is just one of the most infectious viruses, Jay.
it is. And I think, the things that I've been, talking about a lot, you've been talking about, so many of our colleagues in public health around the country, is the importance of vaccination and the fact that we are losing this battle. And I am really worried about the school season, right? Kids are now back in college. They're back in their daycare, et cetera. This is the time when kids are now all congregating together in schools. And as the weather gets colder throughout most parts of the United States, people spend more time indoors. This is the absolute worst time to be entering school in a place that has low measles vaccination rates. And this is a disease for which we don't actually have a cure. We really do only have vaccines as our most effective way of preventing people from this illness. So just a call to reminder to people to really emphasize that. And the other thing I'll just make a quick point about is also indoor air quality, right? One of the things we that can reduce transmission for such a highly infectious disease is to have standing room air purifiers, centralized HVAC systems with high efficiency filters in them. And so I'm hopeful that, in communities, particularly in those that are not so great on vaccination, might at least be willing to embrace certain other basic infection prevention measures.
Yeah. And Jay, last thing to bring up, maybe that's worth saying, is the majority of these cases we're seeing in kids are unvaccinated kids, right? Or kids with low level protection. So we need to keep those rates up.
Yeah, vaccination is incredibly effective at preventing infection. A single dose can provide lifelong protection in a very large percentage of people. We give a second dose of the measles vaccine, ideally before age 5, because some people do not respond adequately to that first dose. And that second dose ensures the very high success rate we have at this vaccine. Okay, let's go
Okay.
on to another virus that does have a vaccine that's being developed and evaluated in places, but is now starting to spread. And we even have a case locally here in the New York area where you and I are based. And this is chikungunya, which is a virus that was previously thought to be a tropical disease. But as climate change has made a lot of places to be more like tropical places, this mosquito-borne virus, which causes, fever and, debilitating arthritis that can persist in people for months and years afterwards, is spreading rapidly in France and Italy right now. And so they're seeing a major surge. Now, a few weeks and a few months ago, there was a massive surge as well in China, particularly in Guangdong province, which is in the south of China. And what we saw recently was reports of actually a locally acquired case out in Long Island. And there's been some investigation to try to figure out, is that a mosquito that hitched a ride, or is that from a local transmission where somebody had chikungunya, a mosquito bit them, and they spread it to somebody else? So, John, what do you think about this?
It's always worrying when you have a case pop up with no travel history, because we've had a history in the United States. Not the first time we've seen chikungunya here. Back in 2004, we had 8 cases in Colorado that had been vacationing, I believe in the Andaman Islands and the Indian Ocean, got infected there and brought it home. But there was no local transmission. And fortunately, it was wintertime, so there were no mosquitoes around to even transmit it. The issue in New York is, while we don't have the main vector, which is Aedes aegypti, we do have Aedes albopictus, which is a mosquito capable of transmitting chikungunya. So we need to pay attention to this.
Yeah, and there's a large, population of immigrants from tropical countries, particularly from the Caribbean region, in and around that area in Long Island. So it is certainly possible that this was a locally transmitted case, because you have a mosquito, the vector that can transmit it, and you have a population that could potentially have undiagnosed infections, because we know not everybody does develop symptoms.
That's right. And with so much air travel between the Caribbean, where chikungunya is circulating, and the New York area, it's not unthinkable that a mosquito could be, stowaway in the cargo hold, kind of like when West Nile was introduced to New York. So,
Yep.
yeah, it's explainable. And Long Island is, of course, where JFK is.
Exactly. Okay, so let's go in next to bird flu, which we haven't talked about in a while. We used to do a separate segment entirely about bird flu.
That's right.
But there have been no human cases of H1N1 reported since the beginning of August. And in the US, however, there has now been a surge, in infections occurring in animals, particularly in poultry flocks. And there's been an increase also in the amount of H5N1 bird flu virus that's been detected in wastewater. So that is basically sewage sampling to see, is it possible that this virus is circulating in communities? And you're seeing those increases in Minnesota, in Kansas, and even in New Jersey. And John, there was also a cat, and you and I have talked a lot on the show about infections occurring in cats. So, and now it turns out there's also a domestic cat in LA, just as there was, I think, earlier this year, that appears to have gotten sick from eating raw pet food.
That's right, Jay. We had 2 cats in New York City that got infected eating a raw cat food diet that had poultry from an infected farm. This is probably a similar instance. 2 cats in Los Angeles, indoor house cats, probably unlikely exposure to any wild birds or other, farm animals, had raw food diet, and also were diagnosed with H5N1. And cats do get sick. They present with severe neurologic symptoms. So veterinarians are now kind of on the lookout for this, knowing that there is the potential for this dietary transmission.
So, John, do you think that there's going to be a surge in bird flu infections in the fall? Where would be your guess?
On poultry farms?
Basically everywhere. I'm curious whether or not. So, I mean, just to throw this out there, I know is a difficult question. This might be like asking who's going to win the Final Four this year. But you and I and many other experts were really worried earlier this year about the rapid spread of avian influenza throughout all different types of animal species here in the United States, and the spread on dairy farms. It does appear to have slowed down, and so we don't know, obviously, whether that's due to less testing and public health infrastructure, which we know is an issue, or is it due to control measures actually did work? There was investment by this administration in trying to strengthen infection prevention and control on farms. Or is it just a seasonal variation that we're expecting to see these things come back? Where would be your best guess? Or
Yeah.
you can also plead ignorance too.
No, well, that I always do, but I think it's, if I had to guess, it is interesting. We still have it circulating on poultry farms. I think the reports on dairy farms have been quiet, but it's still there in poultry. So we are heading into influenza season in humans in general. So we're going to see more flu cases. I don't know that we're going to see H5N1 cases in people, but testing is there. I mean, I think states have the test. If there are people, coming in with flu, and they have a history of working on poultry farms, they're going to be screened. So my guess is, I don't know that we'll see a surge in H5N1 specifically, though we'll see the usual uptick in flu cases.
Okay. And then the most important message I think we can get to people out there is, if you are a pet owner, please do not feed them raw food diets. In addition to putting your pets at risk for a whole range of bacterial infections, you are also putting them potentially at risk of avian influenza, which is both disastrous for your pet, but also potentially for you and your family members as well. All right, Jon. So one more food safety issue before we get into our extended topic of the week. And this is a outbreak of a disease that we've talked about before called Listeria, but this is a different outbreak of Listeria. So what we're seeing right now is there's an outbreak of Listeria infections in 15 states that have sickened 20 people and killing 4 of them. So just as a reminder, Listeria is a bacterial foodborne infection that can be transmitted through a whole range of different food products, but is particularly common in foods that are kind of processed and packaged, because it can persist in the environment of factories that produce this type of food. And one of the things that's also most worrisome about Listeria is it's one of the most deadly foodborne infections you can get. And this outbreak has been linked to a number of different food products: pre-made chicken pasta meals that were sold at Walmart and Kroger, a linguine with beef meatballs dish that was sold at Walmart, and a Cajun-style blackened chicken breast fettuccine Alfredo sold at Trader Joe's. So, Jon, what do you think about what's going on here? That's a lot of different food products from a lot of very high volume places.
That's right. And all I can say is, we're fortunate to have a food safety system in this country that will pick up on these. We have such an industrialized food supply. Food gets processed, sent out all over the country, that it'd be way worse if we weren't picking up on these cases and linking them to food supply chains and being able to trace them back and recall them. So these things do happen. Most importantly, we don't want them to happen, but the important thing is that we notice when they do, and we're able to get those foods off the shelf.
Yeah, without question. And this is, again, we're very pessimistic on this show, particularly me, about what's happening to public health in the United States. And it's just, again, a reminder that, the system that keeps food safe here in the United States is one that you do not find in many places around the world. And that is thousands of people working in esoteric, interconnected systems to inspect food manufacturing facilities, to inspect food after it is sold in those places, to evaluate laboratory specimens and perform very extensive genetic testing on them, epidemiologists scanning data from animals, from food, from humans, to look for these things and then eventually investigate them. And as you point out, it is not expected that in many places around the world that you would be able to trace an outbreak of so many different food products across so many different locations, right, unless you had all of these sophisticated systems in place, staffed with all of these people who are funded entirely by government, right? These aren't private people that are out there, private detectives investigating this. And so, I'm thankful that we're detecting these outbreaks and controlling them. But I do worry that as time goes on, it may be that people get infections like this and we never do quite figure out the source.
Yeah. Well, we'll hope that the states can, pick up some of the slack too, in the absence of federal support for it.
Yeah, and that's absolutely true. And I guess the biggest important reminder to people is, watch out if you're eating, pre-cooked meals that have been made at Walmart and Kroger that are pre-made chicken pasta. You've bought linguine and meatballs from Walmart, or you're a Trader Joe's shopper, like a lot of people that I know. Check those recall lists and make sure you don't have any of that food still in your home. And if you do, make sure to dispose of it immediately.
Okay, now on to the good news, right, Jay? This is
Exactly.
the
So
uplifting segment of the show.
exactly. So our longer segment today is going to be about a topic that is a bit, I think, technical for people, but I want to make sure that we have covered this because I don't think it's something we talked about very much, and that is what's colloquially known as superbugs or drug-resistant infections. So this is basically, any type of bacteria or virus or other type of microbe evolves over time, right? Every time it divides and replicates, there are errors that are made in that replication process, and it gives them the possibility to mutate into a form that means it is no longer going to be killed off by any of the drugs that we use, the antibiotics we use to kill them off. And of course, when we use these drugs too much, we increase the amount of pressure on these bacteria and viruses to evolve. And there's been an alarming increase, over 460%, in a particularly dangerous strain of superbug. And that strain has been rising from 2019 to 2023. And it's specifically known as an NDM producing carbapenem resistant Enterobacteriaceae. Okay, very long, complicated term. Let's just call them NDM CRE infections. Okay, so these superbugs are spreading in hospitals and other healthcare settings, and they're putting patients' lives at risk, particularly people who are coming to the hospital not because they have these NDM CRE infections, but because they have something else. And the unfortunate bonus or harm that they're getting is getting this dangerous, highly drug-resistant infection when they land in the hospital. So, Jon, what do you think about this sudden rise in the United States over the past 5 to 6 years of these dangerous superbugs?
Yeah. So we've seen this before. And I guess just to zoom out for a second, antimicrobial resistance, or what you're talking about is, bacteria acquiring resistance to our antibiotics is a major global health threat. It's really up there in the same vein as zoonotic infectious diseases, as pandemics. AMR, or antimicrobial resistance, is really the other side of the coin, if you will, that the global health community sees as a major, major threat to human health. And there's a whole slew of reasons as why we see resistance evolve. It can be overuse of antibiotics, inappropriate use of antibiotics. And Jay, just to add to something you said, that you're absolutely right that microbes like bacteria can acquire resistance genes and then evolve. But what also happens is when we use antibiotics, there are some that are susceptible that the antibiotics kill, and those that are naturally resistant. Some antibiotics resistance occurs naturally in bacteria. And if that happens to be the bacteria causing disease, it will be resistant already, and we select for it. We wipe out the bacteria that are susceptible, but leave the ones that are naturally resistant, and then they're able to be spread.
And
So,
John, let me interrupt you there and add yet another. That's an excellent point, but let's add the other factor in there too. These microbes are promiscuous, right? They also
right,
exchange genetic elements.
they
So,
do, they do.
why don't you explain that a little bit as well too?
That's right. So that goes in the vein of the sort of evolution or acquisition of resistance traits. Bacteria will share genes, and part of their genes that make them resistant to a certain class of antibiotics can be passed on to other bacteria. So that can lead to resistance as well. So what it all means is the scientific community is aware of this, and we have to continue to support the development of other antibiotics because it becomes an arms race. If we don't have drugs that can kill the resistant bacteria, then the bacteria are going to be able to cause more and more disease. So we got to keep up with them. And getting back to hospital acquired infection, because that's what you're talking about here. We have seen this with other types of bacteria, with Staph aureus, MRSA, methicillin resistant Staph aureus, which can sometimes be a hospital acquired infection too. And so infection control in hospitals becomes super, super important, because you don't want to go to a hospital and become more sick than you were before you came in. And so this is a real, I don't want to say struggle, because a lot of hospitals are very good at keeping a sterile environment, but it happens. And if it's a resistant bug, it can hang out sometimes, even despite control measures.
Yeah, absolutely. And hospitals are difficult places for this. They're the epicenter essentially of these for several reasons. So first of all, you have sick people in a hospital, so they are of course highly susceptible, right? Their immune systems are compromised in some way because of their illness. Number two, they're in a crowded setting where they are constantly in contact with artificial devices, plastic being inserted into their bodies, procedures being done, staff moving in and out. So there's so many opportunities to come into contact with something that might be contaminated. The third is there are lots of antibiotics being used in that hospital. So it's actively selecting for driving evolutionary pressure to get more of these highly drug resistant infections. These NDM, CRE type infections have the opportunity to evolve. So they have the opportunity to evolve. They have the opportunity to spread easily, and they've got people who are at really high risk of getting these infections. And I think what's challenging for people to understand oftentimes, because I worked on this problem a lot globally, is that it's not easy to stop. You have to be incredibly rigorous in
Yes.
your hospital to make sure that patients are not getting these infections from healthcare workers not washing their hands, equipment not being sterilized in some way, or some other pathway, because these are really easy to transmit, and they're very dangerous because there basically aren't any antibiotics that are susceptible that work very well for these infections.
Yeah. And Jay, maybe it's worth talking about some of the strategies we can use every day to limit the potential for resistance to develop in bacterial infections. For instance, like when we go to the doctor, if we have a bacterial infection, we're prescribed antibiotics. So Jay, tell us like what's important to do with your antibiotic prescription.
Yeah, I would say there's a couple of key, really important things here. And there's been some important progress since we've had COVID. So when it comes to drug resistant infections or antibiotic resistant infections, here are just a couple of really important points for people to know. Number one of the great things about these like at-home COVID and flu tests is you can find out relatively quickly and relatively cheaply whether the sore throat fever that you have is due to a virus or due to a bacteria. So I would really encourage people, if they have the resources out there, to stockpile on those tests and make sure they test themselves first. Okay. Before you go to the doctor and try to decide, oh, do I need antibiotics or something? See, most likely this is a standard virus infection. That's number one. Number two is when you go to see a healthcare provider, trust their judgment when it comes to whether or not you need antibiotics. A lot of people are like, hey, I just want something just in case. The problem is with those just in case antibiotics is if you have a virus, it's not going to do anything to get rid of that virus. And number two is it's going to alter your microbiome, the bacteria that you have living in your body normally. And that could select for a resistant strain of bacteria
Mm-hmm.
that could eventually be spread throughout the community. Every dose of antibiotics, it puts ourselves at risk for it. And the third is if you do actually get prescribed antibiotics, take them the way they have been prescribed to you for the duration of the time, because we know that we want to make sure we rid your body of that infection, and taking antibiotics haphazardly and then stockpiling them for the future, again, creates another opportunity for bacteria to slip by and to evolve in a direction that is not good for any of us.
Yeah, that last point's really important. I think sometimes we're tempted because we start feeling better. Oh, I don't need to finish this prescription. I'm already feeling better. And you can just toss the rest of it when you might have a few days left. But the truth is, you can still have low levels of bacteria in your system that haven't fully been killed by the antibiotics, even though you feel better. And they're just not enough to make you sick. But if you leave them there, they can regrow. And again, this can select for those that are going to be potentially more resistant to treatment next time.
Yeah, absolutely. Okay, John. So the key message for everybody out there is, especially as we're heading into the winter virus season, is do what you can to stay healthy, wash your hands. If you're in a high risk area and you feel up to it, use a high quality mask, improve indoor air quality. And if you do get sick, use those diagnostic tests to help you maybe avoid having to see the medical doctor and hopefully ideally avoid taking antibiotics as well.
That's right. And if you have a doctor who just gives you a broad spectrum antibiotic, that's a drug that is kind of a catch-all that would, they think, well, maybe it's this or maybe it's that, and just start taking this. You can actually ask for a culture or a test to try to identify whether or not it's a bacterial infection making you sick. And if so, what kind of bacteria, which will lead a doctor to prescribe a more precise type of antibiotic to affect that one bug. So it's important that you as a patient can also ask to be tested or ask for a culture so that you're not unnecessarily taking an antibiotic.
Yep, absolutely. Okay, John. And with that, thank you everybody for watching and listening today. If you like what you're hearing about public health and infectious diseases, please hit the like button. Please hit subscribe. Please share these episodes with other people in your life. And also leave some comments. Let us know if you like the new format that we're doing, where we're doing a run through of antibiotics, not run through of antibiotics, run through of outbreaks. Because I think we're going to try to do this for a little bit and see how it goes, because I think it's a way for us to touch on sort of a broader range of topics than we might normally.
Yeah, we love feedback, so please keep it up. And thank you to those who are subscribing and listening. We appreciate you too.
Yep, absolutely. All right. See you next week, Jon. Bye-bye.
Take care, Jay. Be well.